Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Life is uncertain. It's okay to feel stressed, anxious, worried, or frustrated. CalHope can help. Access CalHope's free and secure mental health resources. Call 833-317-4673 or live chat at calhope.org.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
June 1924. A 20-year-old Japanese female who was admitted to the medical clinic of Tokyo University Hospital with a headache and general fatigue. On admission, physical examination revealed a temperature of 102 degrees Fahrenheit. That's 38.9 degrees Celsius. Cyanosis of the lips, apathy, drowsiness, slight neck rigidity, a positive Koenig sign, and rigidity of the right leg and left hand. On the blood tests, the patient had a leukocytosis. On the 6th day after admission to hospital, the patient died of a sudden respiratory arrest. Dr. Travis Brown, another episode of This Medical Life, and this... Oh, sorry, I thought there was a mosquito that just got in. I'm a little bit touchy. We've been told to be very aware of them. Welcome again.
Thank you very much. Yes, be aware of the mosquitoes. That is a good advice. We're talking about Japanese Encephalitis Virus. Now, we often don't do topical episodes, but look, this is timely, and it gives us an opportunity to explore learning about, first of all, where the disease comes from, but sometimes it can actually give us an opportunity to see what do we know now and what is our plan forward. And the interesting thing about Japanese encephalitis virus is we started to get outbreaks of encephalitis in the 1870s. And so we're not actually, it's interesting because encephalitis, there can be a number of causes for it. So when we're, seeing through history this encephalitis, what is special about this? Well, this one looks like it's clusters. So when you have clusters of, a symptom, what is the linkage? And so this is, why is it the 1870s? This is as far back as the records go. And so did it happen before this? Certainly. It would have had to have been happening before this, but we don't know how far it goes back.
So this is going to be another one of those episodes of detective work in the medical realm.
Well, it is. And this is where you can see, doctors and scientists drawing together the information that we have. Now, what was interesting or what was sort of unique about this, these outbreaks? Well, they tended to occur in the summer seasons, and the patients got encephalitis symptoms. There seemed to be an outbreak that would happen about every 10 years. And, the first major epidemic was in 1904. Now, we still didn't know what it was. And at the time this was in Japan, it was called Yoshiwara cold. Now, I'm trying to find out why it was called that. Was it after the person who suffered it or the person who was diagnosing it at the time? Mm. So we're not quite sure, but there was these little outbreaks happening. And then we have this epidemic in 1924 where there was over 6,000 cases. Now, that's really significant, which we'll come back to later. Why so many cases? But then we see there's these outbreaks of these encephalitis episodes. It happened in 1927, it happened in 1934, and it happened in 1935.
October 1934. A 16-year-old Japanese female who was admitted to the medical clinic of the Tokyo University Hospital with fever and marked fatigue. On admission, she had a temperature of 101 degrees Fahrenheit, that's 38.3 degrees Celsius, lethargy, apathy, severe headache, and neck rigidity. On the following day, she fell into a stuporous state, and marked rigidity in the neck and left extremities was noticed. She then developed tremor of the right hand. She died on the 12th day in hospital.
So what we're seeing is these cases present. So detective work starts to happen. And from the 1924 epidemic, they were clearly doing autopsies at the time. And there was a doctor by the name Dr. Wake who went back and examined the autopsy material that they had taken from 20 patients. Now, he categorized them into three different categories. One was in the acute phase, and he had 9 patients. And these patients had been unwell for about 1 to 2 weeks before they died. There was 8 who were in the subacute phase who had been unwell for 2 or more weeks. And then there was the chronic phase. There was 3 patients. Now, these were patients who had had it recovered or seemingly recovered months to years after the initial event. But they had some permanent disability, some residual effects from this illness. And so mainly focusing on the brain, the CNS findings, the histology findings, he again put it into these classifications. And what did he find with the acute phase? Well, there was areas of degeneration throughout the brain. There was congestion, and there were small hemorrhages going on. There was severe damage to the nerve cells, and there was minute areas of necrosis. So this caused these patients to die very, very quickly. In the subacute phase, there was scattered inflammation, there was localized lesions, and there was also degeneration and loss of the nerve cells, which brings us to the chronic stage. And so patients who had recovered still had degeneration of the nerve tissue, but they also had other findings, such as fibrous thickening of the vascular walls and post-inflammatory changes. So it was clear this had to be an infection of some sort, but they still didn't know what it was. But it was causing people to become very sick very quickly and die very quickly if they got to that level. And this was not of the traditional people who you would expect, the very young and the very elderly. This was of healthy young people. And this was a surprise.
A 7-year-old Japanese female with vomiting, headache, and lethargy beginning 8 days prior to death. A few days after onset, she had a temperature of 104 degrees Fahrenheit, that's 40 degrees Celsius, and pupil dilation. The day after the onset of the disease, she was admitted to the pediatric clinic of Kyushu University Hospital with fever and pain in the neck. On admission, she had neck rigidity, Koenig's sign, tremor of the extremities, impaired light reflexes, and an overactive knee jerk. She continued to run a temperature of 104.2 degrees Fahrenheit, or 40.1 degrees Celsius, and had a leukocytosis. She went into coma with dyspnea and died on the 8th day.
So by 1935, they are actually able to transmit this agent. And they got this from the brain of a patient who had died and were able to transmit this to a monkey. So they confirmed that this was an infectious agent. Now, this presented an opportunity. So even if you don't know exactly what the agent is directly, you may be able to find out what it is indirectly. So we do this all the time now in medicine, and we use serology. We actually test the immune system. And so if I can see, well, if I can't find the agent that someone has, then maybe I can find the agent would show that you had it. And we do this all the time now. Infections such as EBV or CMV, HIV, hepatitis, we actually measure the immune response to see if you've got it. Because if you go looking for the virus, sometimes it's not there, it's been and gone. And so we started to do this testing in rabbits. But rabbits, unfortunately, weren't a really good model because they didn't show the same neurological changes as humans did to this virus.
Oh.
They also tried it in cats, but again, same result. but they did find the result was effective in monkeys and horses. They got similar neuropathological findings as we get in humans. Now, throw a spanner in the works of all this investigation, and you've got World War II.
Of course, because we're talking the mid-1930s, late 1930s.
That's right. Going into that. Now, you have an influx of soldiers and military personnel into an endemic area of this virus, and they started getting sick. They started staying in these areas for long periods and being exposed to it. It was even in the Korean War. American servicemen started becoming sick, and they were diagnosed initially with what was called war neuroses. So they were misinterpreted and thought, oh, this is the, shell shock, or this is the, problem with war. Well, actually, no, it was Japanese encephalitis virus.
Travis, could you imagine there's an army and a war happening during the time of this great infection? It wouldn't happen these days. In the middle of a pandemic, no one would send soldiers off. Oh, yes. Continue.
Alas. So, but then we're starting to learn more and more about this. And Japanese in the JEV virus is actually a misnomer. This is an area that spans 24 countries and is endemic in these regions. So this includes major areas such as China, India, Southeast Asian Peninsula. And so as we continue to understand, we started to know more and more, and you would get these outbreaks because we knew to look for it. And despite our advances, these epidemics continued to occur.
A 10-year-old Japanese female admitted to the paediatric clinic of the Kyushu University Hospital. On admission, she had a temperature of 101.8 degrees Fahrenheit, or 38.8 degrees Celsius, neck rigidity, Koenig sign. The patient had a leukocytosis. She went into coma and died on the 4th day. Dr. Travis Brown, that was quite a sobering opening as we talk about Japanese encephalitis. Where do we go from here?
So what do we know about this virus? And again, it is called the Japanese encephalitis virus. Now, this is what we call a flavivirus, and this is a family of viruses that are primarily found in arthropods. So they're in ticks and mosquitoes. And look, what we have is occasionally humans get infected. So this falls into the category of diseases such as yellow fever, dengue fever, Zika virus. And so this is that in that family. Now, we know that JEV has 4 genotypes, 1, 2, 3, 4. It's a small virus. It's 50 nanometers, and it is enveloped. It's a positive single-stranded RNA virus. And we actually don't know the origin. And, it looks like it's possibly come out of, an African ancestral virus. It's closely related to the West Nile, St. Louis encephalitis, and Murray Valley encephalitis. And the interesting thing about that from a genetics point of view is it means it's closely related in like a tree that you see, here's these viruses when you look down it.
Is the Murray River one the reference to Ross River virus? Is that the same?
Different one,
okay.
but in that kind of field. But the point about this is when it's closely genetically related, it will also mean it's closely physiologically related, meaning that our bodies will respond similarly with similar antibodies. And so they won't cross over, so to speak, because they're for different diseases, but in testing, they can cross over a little bit. And so it's sometimes hard to distinguish, is this exactly the antibody for something such as, Murray Valley virus, as it would be for Japanese encephalitis virus. So you need to keep that in mind when you're doing the testing. Is this real reaction for the virus that I think it is? Now, what causes these epidemics? Well, we don't know. And that's the hard thing. This infection and these spillover events are continually happening. We'll discuss that in a moment. But why does suddenly a whole bunch of people start getting this disease when it's just about all the time anyway. And so we know that humans are not actually the definitive host. We're an intermediate host, and we're a bad one. We're a dead-end host because the virus can't, it doesn't cause a large viremia, and it means that it doesn't pass on to us. So excuse the language, dead-end host. That's not meant.
We didn't take it personally.
And so the whole point behind that is when we go looking for it in humans, it's actually really hard to find because we don't get a really good viral response. If we look in animals such as pigs and wading birds or water birds, they actually they are the definitive hosts. So they get a really good viremia. And what's often called mosquitoes will come, bite an infected animal, get the virus, and then bite another animal. And that's the life cycle that it goes around. There's a certain species of mosquito that they say is the most culprit. I don't often take notice of that because it's a mouthful of a name and it doesn't actually mean much clinically.
Come on, say
for
it.
Me. No, I can't even say it. So, but they're often called, in Asian area, rice paddy mosquitoes. That's because they're in waterways with the water birds. And so this is what happens is somehow in this time, mosquito, pig, water bird, and it just cycling around, and then a mosquito bites a human or a horse and a donkey, and they start getting unwell. And this is why it was so impressive in 1935 when they were able to identify it, because it's not actually a large amount of virus about in our bodies. So this is a response. And this is why it's important to know what you're testing for, because I will come back to this and reiterate it, because when you're trying to test for the virus, everyone will think PCR is the best test, except for the virus isn't always about when it's there. And so if it's a negative PCR, doesn't mean that it's not there.
Right.
Or it wasn't there. And so that's important to note. And so we have an average at the moment around the world of about 50 to 70,000 cases of JEV each year. And we've known it's been in the north of Queensland about. The most people who we were worried about before were travellers. And it's actually really, really rare for travellers to get an infection. If you're going into Asian areas, about less than 1 per million traveller from a non-endemic region actually gets JEV.
Is that because they're just not there long enough in the random selection? That's
right. And so people who are at higher risk they have to go to an endemic country normally for over a month. They need to go visit the rural areas and do usually extensive outdoor activities. Right. And it's even a little bit higher in the seasonal times. They often need to stay in accommodation without mosquito nets or any preventatives in that way. And even then, it's still rare. And so it's actually quite hard for travellers to get. And this is why people have, often been given advice, do I need to have this vaccine when I'm going traveling in Asia? And it's like, well, unless you're in a high-risk area for a long time, probably not. And so the really interesting thing about this, and the important thing to emphasize, is that clinically, over 99% of the cases are either asymptomatic or they just have this mild, non-specific febrile illness. So the vast majority of people may not even know they've got it, or just have just a really mild fever. And that's really important to emphasize, because whilst we had a sobering first part of that episode, the significance is that is less than 1% of the cases. Right. So there's people who get severely ill and are really quite rare, which is why these epidemics are really interesting, because something must happen for a lot of people to become unwell. And they just come in peaks, and we're not quite sure why. So the incubation time for this illness is about 5 to 15 days. Again, it will start off, if it's starting to get into more severe territory, as non-specific. So people will get, fevers, diarrhea, rigors, which can then lead to headaches, vomiting, and generalized weakness. The part that really becomes concerning, though, is when they start getting neurological changes, neurological symptoms, such as change in mental status. If they get focal neurological deficits, such as paresis, hemiplegia, tetraplegia, or cranial nerve involvement, this is when it starts to become really concerning. So you can also get movement disorders, and then at the really late stage, you can get coma. Now, the challenging thing for this is that they can happen, these symptoms can be rapidly progressive, and sometimes it even goes more faster than that. They get a febrile illness that develops paralysis on one or more limbs, often in the lower limbs, and is often asymmetric. And if children get it, seizures are common, and it tends to be a generalized tonic-clonic seizure. And then for in general, the poor prognostic signs for patients is, patients who get multiple prolonged seizures, if they have raised intracranial pressure, or if they get flexor extensor posturing or respiratory changes. Now, the people who are mainly at risk, again, tend to be very young and old, but as we've seen from the cases, that's not always the case. And I did ask, Dr. James Layden, who is a neurologist, is there any important tips or advice about JEV? And he said the signs that probably the symptoms that I've rattled off tend to be late signs, and they tend to be, someone who's got advanced disease. So the real key is need to treat delirium and altered conscious state with great caution. And so if that needs to be a red flag for anyone who's come across those symptoms, and if it's unexplained, then this needs to start to be a consideration. And we do know that about 50% of patients have raised intracranial pressure. If we look at their CSF, they have lymphocytosis, so increased lymphocytes. Now, when we start looking at the serology, you can look at serum, you can look at CSF, you can look at urine. I'm not sure who's looking at urine because we just get much, but it is available as a body fluid to test. But the problem with serum is it could indicate an asymptomatic infection as well in an area. So the main reliance on a test will be CSF. And if you have a serology, an IgM, so I often abbreviate that to immediate, and IgG is the longer term one. If you have an IgM in the CSF, it is very suggestive that this is a JEV infection. And so what do we know about the antibodies? Well, antibodies are detectable in 70 to 90% of patients who have JEV. And we have them detectable about 5 to 8 days after the symptoms onset. And so patients who admit to hospital, most of them, about 60 to 70%, have serum antibodies. And so once you've gotten past 9 days, almost all of them will have these antibodies. So it's important to note if someone comes in on day one, they've just had altered consciousness, they may actually not be positive. It depends on how long they've had the illness for. So it's just important to note that. Serology, unfortunately, also crosses over with dengue, Murray Valley Encephalitis, and West Nile virus. So this is why it is important to know your tests. And again, PCR is great if it's positive, but it may not be positive even if they have JEV.
Yes, we get that bit, but here's the thing that's bugging me, Dr. Travis Brown. These are the people where the symptoms have shown. You mentioned some people can be asymptomatic, which just means it could keep getting more developed until when it does show signs, it's at a worse stage. So in this case, the blessing in disguise is to get the symptoms early as a patient.
Well, the really hard thing about all of this is there's not a whole bunch we can do about it. And so we're trying to do the supportive treatment. When we look at it, we will see that the mortality rate of patients who are hospitalized is 20 to 30%. So that's why, the vast majority of people won't go anywhere near a hospital. They will be fine. The patients who present, though, are severely ill. And so if they're presenting and they've got neurological signs, unfortunately, about a fifth to a quarter die from the result. And even of that, the people who survive, about 30 to 50% will have long-term residual effects.
Right.
And some people will even recover, be discharged, but there will be some, about 20% will deteriorate after they've, recovered from it at a later date. And so it's such a hard area. And this is the challenge, is because, what are these complications? We're talking about upper and lower limb weakness, cerebellar and extrapyramidal signs. They can have cognitive or language impairment, psychiatric problems, recurrent seizures. If it's children, they recover about, they say 50% have learning and behavioral issues. One of the things that is interesting, and we don't know enough information, so I put this information with a star next to it. People are worried about pregnancy and JEV, and we have very limited evidence of the implications. But the problem in pigs is we know it causes stillbirths in pigs. We'll come back to that later, but there was a very tiny study of 9 pregnant women who got JEV, and 4 of them miscarried. They happened to be in the first and second trimester. So does it increase it? Possibly, but we don't have good evidence. And if someone does become infected, they seem to have lifelong immunity. And this is where we draw in the vaccination status. And there is vaccinations available. I believe there's 2 in Australia, 1 for children, 1 for adults. And who is this for? Well, this is for people who are working in the abattoirs, in the piggeries. Veterinarians are recommended, people in the pig industry. So, the important point, you can't get it from eating, pig products or anything. And you can only get infected from a pig who has been bitten by a mosquito, who has the infection, and then human gets it. So we do know a lot about it. There are some important points that you can clearly see, will cause hysteria with, I don't eat pig products. Or, no, we don't get it from that. But it's going to start to have to creep into our differential diagnosis in patients who have encephalitis.
But also people who work in and around shallow water, a lot where there are high incidents of mosquitoes. You would think I'd be tempted to see if I could get that vaccine. Dr. Travis Brown, let us bring this home now. And, just before we ended that break, I was wondering about when I might qualify to get one of these vaccines. So let's actually bring it right down to the Australian level. We have had encephalitis being talked about more in our news. Can you give some sort of context to this discussion?
Yeah. So, look, we have had JEV in Australia. The first case was in 1995 in the Torres Strait, and then we actually noticed a case in 1998 in Cairns. And it is about, and it's only traditionally been in North Australia. Honestly, the first part where people started to notice seemed to be when they started noticing a number of increased in stillbirths in piggeries. And this alerted to the fact that something unusual's happened here. Now, the piglets, the stillbirths are called mummified piglets, and this is because they die in utero, and are often there is an appearance that they've often died for a while before they are born, and it's an appearance that's why they call it. Mm-hmm. And so that alerted us to the fact that, wow, is this a little bit more widespread than what we think? We've ended up finding it in 40 piggeries around Australia, and this is in Queensland, New South Wales, Victoria, and South Australia. And this is because of the domestic pig rearing, and so once it gets into that population, if you've got mosquitoes about, then yes, it actually could get into your, pig rearing or your piggeries or wherever that is. Yep. The balancing act here is the climate change. And so we are getting warmer. And one of the projections, and this is drawing in a parallel to malaria, when you start to actually get warmer climates and it gets hotter, and you can get more spread of mosquitoes. Well, the more spread of mosquitoes means more diseases can be transmitted, and this is important not just for JEV and malaria, but things like dengue fever, Murray Valley. As soon as you start getting larger populations of mosquitoes, then you can actually find transmission of other diseases going along with that. And so that's important. Not only that, we've recently had a whole bunch of flooding, extreme weather environments in Australia.
Well, we've got, it's heyday for mosquitoes in the wake of all that flooding.
That's right. And so if you have, not only that, you have then water birds coming to areas that they may not have come before. And so you've got pigs, water birds, mosquitoes, severe weather environments, increased flooding. And the other thing is you've got a naive, immunologically naive population who can be susceptible to this. It's not endemic in Australia at the moment. And so we are then able to be susceptible to this infection. And so there have been a few deaths. It's at the moment, it's less than 5 that we're aware of. So this isn't panic stations, but it is important to note that anyone who presents to hospital now with unexplained encephalitis or meningoencephalitis symptoms, this has to be on the differential diagnosis. So look, that's the advice coming out of public health and doctors, that it needs to be a consideration with someone who presents with neurological symptoms or unexplained encephalitis symptoms. The important part is know what you're testing for, know the limitations. Again, PCR is of limited value, but serology, particularly CSF serology, so lumbar puncture, is important. But check with your lab, because the labs that I've looked at, you need at least 1 mil of CSF, at least 1 mil, for them to be able to do this test. Chances are you're also doing other tests at that point in time. So need to make sure, ask them, how much do I need to do these tests? And you can do blood, you can do PCR, but again, serology is the main thing. Be mindful that serum can have cross-reactivity. All of them can have cross-react, but serum, you can have asymptomatic infection. So that will be, important. If it's in the CSF, where it normally shouldn't be, well, that's significant. So I guess the sad thing about this is we don't have good treatment. And the best that we can say is supportive care. So this is management of the intracranial pressure. This is seizure control. The evidence, we don't have at the present any antivirals that are in assistance, and the controlled clinical trials didn't show any improved outcomes with interferon alpha or corticosteroids. So that's the challenge, is that the reassuring things, vast majority of people will either be asymptomatic or just have a mild febrile illness. So in that instance, that is good. Those who become unwell, though, they're in difficult territory.
Wow. 2 things I'll take away from this. One is PCR tests are not the panacea for everything. There you go. How's that? And the other thing is I need to take seriously going out on balmy evenings to swap out the cologne for tropical strength mosquito repellent. Should be my new modus operandi. And you'd concur with that, wouldn't you, Travis?
Certainly would.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a PathNotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.